Hello everyone, hope you're all doing good. This is Dr. Agalya Kulendevelu, your organic faculty, and in this video we are going to discuss about cervical intraepithelial neoplasia. See, this video is very important because the basics of this will be helping you with learning of CA cervix also. Okay, so I tell you that you have to do this module first, then only you have to go for CA cervix. Okay, now let's start this. Cervical intraepithelial neoplasia. Cervical intraepithelial neoplasia. See, cervix is divided into two parts. One is ectocervix, another one is endocervix. As you see in this picture, you are able to see that there is an exocervix, okay, that is presenting outside, okay, and the endocervix, which is nothing but the inner or lining of the cervix, which is going to continue with the endometrial cavity also. Okay. Now, what is the importance of this two regions? The ectocervix is going to be lined by the pink smooth squamous epithelium, whereas endocervix is lined by red velvety columnar epithelium. Okay. Now, we have to know one transition point of these two, meeting of these two, repeating. We have to know something about squamocolumnar junction. That is nothing but the meeting point of the ecto and endocervix, that is the squamous and the columnar epithelium. Okay. So, that is squamocolumnar junction. Okay. So, this point of meeting of these two epithelium will be varying over a woman's lifetime. Okay. And this will move from outwards towards inwards. Okay. So, if you take the cervix, okay, suppose imagine this is the cervix, okay. So, this is the ectocervix, this inner thing is the endocervix. Now, the squamocolumnar junction is here, okay, and as a woman is getting old, this layer moves from outside to inside. So, it keeps on moving like this. Okay, so the junction will be going like this. Clear? Right. Now, what happens? The zone between the original squamocolumnar junction and the new squamocolumnar junction undergoes metaplasia. So, this will be known as the transformation zone also. Okay, the region between this starting point and this ending point, this region will be known as transformation zone. Okay. So, the newly formed squamocolumnar junction will be the proximal border of the transformation zone. That is what you have to identify. Okay. Yes. Now, let us talk about transformation zone or TZ, I am writing it in short. Okay. So, transformation zone is the region of cervix where columnar epithelium has been replaced by the squamous epithelium. That means one type of epithelium is replaced by another type of epithelium. So, this is only known as metaplasia, and what metaplasia has happened here? It is a squamous metaplasia. Okay. So, this corresponds to the area of the cervix that is bound by the older squamocolumnar junction and proximally by the new squamocolumnar junction. Okay. Yes. So, this is a picture to understand about squamocolumnar junction. You have original squamocolumnar junction here, that is the area where squamous epithelium was present at birth, and as she is getting old, the squamous epithelium would have moved inside. okay, towards inside. So, this is the area of the new squamocolumnar junction. Now, what is transformation zone? The area that is present between the older and the new squamocolumnar junction is the transformation zone. Okay. Now, there are so many types of transformation zone also. We have 3 types. Okay. So, type 1 transformation zone is where the entire transformation zone is visible and the transformation zone is entirely only ectocervical. Okay. And in type 2, the entire transformation zone is visible and it also has an endocervical component. That means it is both endocervical plus ectocervical. Okay. So, endocervical and ectocervical both components are present. Okay. Next is type 3. Here the entire transformation zone is not visible and the transformation zone extends into the endocervical canal only. Clear? So, if you see this, you will be able to understand. Okay. This is type 1 transformation zone where the upper limit of visibility is clearly seen. Okay. So, this is the transformation zone that is clearly visible while you check. Type 2 transformation zone is visible and it also has a endocervical as well as the ectocervical component. Okay. In type 3, you will not be able to see the transformation zone properly while doing a speculum examination because it will be having only a endocervical component. Clear? Right. Now, coming to CIN, that is Cervical Intraepithelial Neoplasia. What does this term refers to? So, this term refers to histopathologic distribution of abnormal cells. Mostly these cells are dysplastic. Okay. So, dysplastic cells in squamous epithelium. So, this refers to mild, moderate or severe dysplasia. This dysplasia can be mild, moderate or severe dysplasia. So, the diagnosis of CIN depends upon the presence of cellular immaturity, then whether there is cellular disorganization or not, whether there is nuclear abnormality or if there is an increase in mitotic activity as well. Okay. So, depending upon the type of dysplasia present, this can be further classified as CIN1, which has mild dysplasia. Mild dysplasia means the atypical cells are seen only in the lower 1/3. Okay. 1/3, that is in the lower part of epithelium. Okay. Then CIN2, that means there is a moderate dysplasia. The atypical cells are seen in the basal 2/3 of epithelium. And finally, we have CIN3 also, which is severe dysplasia. The atypical cells are seen in more than 2/3 of epithelium. Okay. Sometimes it can even involve full thickness as well. Okay. It can even involve full thickness as well. Okay. But one important point you have to understand about cervical intraepithelial neoplasia is that the basal membrane is intact. Okay. Suppose if the membrane is breached, means then it will become invasive carcinoma. Okay. Yes. There is also another classification which divides cervical intraepithelial lesions as the following types. Say cervical intraepithelial neoplasia type 1 is recorded as low grade squamous intraepithelial lesion. Then CIN 2 and CIN 3 are considered under high grade squamous intraepithelial lesion. Okay. So, this is another classification. Okay. So, diagnosis of CIN 2 is often not by absolute criteria. Okay. We can do by P16 immunostaining to differentiate this. Okay. If P16 is negative, then it will go under CIN 1. Okay. If P16 is positive, then we can take them and treat them as CIN 3. Okay. Yes. So, how the changes are going to happen? A normal epithelium will be there. First, cervical intraepithelial neoplasia type 1, then cervical intraepithelial neoplasia type 2, then CIN type 3, and finally this will become invasive cancer. Okay. So, this is how CIN transforms into cancer. Until this, you have to remember, till this basement membrane is present. Clear? Right. Now, let us discuss about HPV and cervical cancer. Okay. HPV is a double-stranded circular DNA virus. Yes, and it is known to infect epithelial cells. There are more than 100 types of HPV virus been identified. We can classify them into low risk HPV, which will be causing benign lesions only mostly. For example, HPV 6 and 11 that will cause 90% of the times only genital warts. Okay, warts in the genital area. Clear? And next comes the high risk HPV type, which will include HPV 16 and 18. Okay, and these are responsible for causing 70% of cervical carcinomas. And among 16 and 18, HPV 16 carries more risk when compared to 18. Okay. Also, we have other types of HPV like HPV 31, 33, 45, 52 and 58. These will cause about 19% of cervical cancer. Okay, right. Now, what happens when HPV is infecting an epithelial cell? There is a change in the epithelial cell which is referred to as coilocytosis. Okay, what does coilocytosis means? There is irregular nuclear enlargement plus there is a perinuclear halo. Okay, when CN disease progresses, this coilocytosis will not be seen. Okay, disease is progressing means then coilocytosis will not be seen, because why? The HPV DNA will now become integrated with the human or the host cell DNA and it will persist in the infection. Clear? And it will cause persistent infection. Clear? Now, let us talk about transmission of human papilloma virus. See, transmission of human papilloma virus occurs by sexual contact. It can even occur by contact with skin, mucous membrane, or even body fluid. Okay. Now, let us discuss how the pathogenesis will happen. Okay. So, pathogenesis, whenever there is early sexual activity or they have multiple partners or the partners with STI, then what happens? HPV infection will occur. Okay. And in HPV infection, remember 80% of them will go for spontaneous regression. 80% of them will go for spontaneous regression or clearance. Okay, there will not be any infection at all. And this happens within 6 to 12 months of the infection. Okay. And the remaining 20% of them will go for persistent infection. Okay. So, when this persistent infected peoples or having other associated risk factors, like for example, they are smokers, there is a reason for immunosuppression, there is HIV infection or combined oral contraceptive pills are used, then what happens? These lesions will be converted into cervical intraepithelial neoplasia, and finally cervical intraepithelial neoplasia and cervical intraepithelial neoplasia will be converted into invasive carcinoma when the host cell genome integrates with the viral genome. Clear? So, this is how it is going to happen, right? Okay. Now, let us also discuss about the risk of progression. Risk of progression to invasive CA. Okay. CIN1, CI2 and CIN3. Let us discuss about the risk of the percentage of regression, persistence, then progress to carcinoma in situ and progress into carcinoma. Okay. Let us discuss all these things in all the 3 types of CIN. Okay. So, in CIN1, there is 60% of chance of regression. In CIN2, it is only 40%, whereas in CIN3, it is only 25%. Okay. And CIN1 will persist in 30% of the cases and CIN2 in 35% of the cases, and CIN3 will be persisting in more than 50% of the cases. Okay. And the conversion of CIN into cervical intraepithelial neoplasia means it is 10% risk, 20% risk. In CIN3 it is no risk because it will directly progress into CA cervix, that is more than 12% chance of conversion into CA cervix directly, whereas the risk of CIN1 and 2 are very less, it is only 1% and 5%. Clear? Right. Now, let us discuss about the screening methods. Screening methods, we will do cytology and HPV testing. Okay. There are some of the inspectory methods as well, that is we can divide, there are some inspectory methods as well, that is we can check by naked eye and decide if there is a risk for CA cervix or CAN like that. Okay. So, this will include via, that is visual inspection with acetic acid. Okay. Next one is villi. This is also known as Schiller's test, that is visual inspection with Lugol's iodine. And the next one is Vyam. Vyam means visual inspection with acetic acid only, but with magnification. Clear? So, this is all you want to know. Okay. Now, let us discuss about cervical cytology, okay, which is very important. That is nothing but your pap smear. It is your cervical cytology. See, remember, pap smear is a mere screening test. That is not a diagnostic test. Okay, that point should be clear. Okay, this is a screening test, not a diagnostic one. Very, very important. Okay, then it can be done in two ways. Either in a conventional pap smear method or a LBC, that is liquid based cytology. Okay. So, best time to do the test is around ovulation, and the position of the patient will be supine, that is dorsolaterotomy position. Okay. And remember, if you are planning on pap smear, while doing you shouldn't do pervaginal examination or use any lubricants. Okay, because while doing pervaginal examination or lubricants, there can be so many changes, like even doing pervaginal examination can bring about a bleeding if any other lesion is present. Okay, so that shouldn't be done. And also you have to advise the patient to avoid the following for the past 24 to 48 hours. Okay, this will include, there shouldn't be any coitus or douching or use of any tampons or even vaginal drugs. Clear? So, how will you do a pap smear? Procedure we will discuss. Cervix is visualized by using cuscospiculum. Then the ectocervix is scraped using Oyer's spatula. Then the endocervix is scraped using cytobrush. The cells are then smeared on a glass slide, and then finally it is fixed with 95% alcohol for at least 30 minutes, and then they will be dried and stained with papanicolor stain, and then the cellular abnormalities will be studied and reported. Clear? So, this is how a pap smear is done. Okay. So, we will use this cuscospiculum. For the ectocervix, we will be using Oyer's spatula, and for endocervix, we will be using the cytobrush, and the cells will be smeared on a glass slide, and it will be fixed with 95% alcohol for 30 minutes, and it will be dried and stained, and by using papanicolor stain, you will be able to find the cellular abnormalities that will be studied and reported. Clear? Right. Now, let us discuss about pap smear adequacy. Okay. For a conventional pap smear, the squamous cells should be from 10 to 12 per 10 high power feet, and the endocervical cells should be between 10 to 12. Okay, that is, the squamous cells should be 10 to 12, as well as the columnar cells are also 10 to 12. Okay, then coming to liquid based cytology. Liquid based cytology is a simple process. You take the brush, you scrape it, and you just put into the liquid box that is given to you. It will be containing a preservative and it will be directly transported to the lab. Okay. So, here what you will do, the adequacy will be like, for the squamous cells, it should be 5000 cells per 10 high power feet, and the endocervical cells can be less also. Okay, 10 to 12. Clear? Now, let us discuss about the reporting system of pap smear. Okay, reporting system of pap smear, that is Bethesda system. Okay, Bethesda 2014 system for cervical cytology. Okay, so what we have is, first point what we have to know is, we have to know the specimen type. So, I told you the specimen type can be either, it can be a conventional pap smear, or it can be a liquid based cytology, or if any other method are used, then you have to mention that also. Okay. The second point you have to know is specimen adequacy. We have seen what is the adequacy needed, right. So, you have to just mention whether it is satisfactory for evaluation or unsatisfactory for evaluation. This is how the report from the path lab will be coming. So, you have to know the meaning of this and what are the components. Okay. And the next one is general categorization. So, general categorization means it can be a negative for intraepithelial lesion or intraepithelial lesion of malignancy, or it can be any others like 1D endometrial cells or CIN, or if you see any epithelial abnormality, that can be mentioned. Okay. And finally, the interpretation or the results. Interpretation or the results. So, this can also be negative for intraepithelial lesion or malignancy. Then you have only non-neoplastic findings, or you have non-neoplastic cellular variations, reactive cellular changes can be associated. Then in post-hysterectomy specimens, you can see glandular cells. Okay, so this is seen in post-hysterectomy status specimens. Okay, so in this status, you can even identify any organisms if present or any epithelial cell abnormalities. Okay. And the next one, what you have to know is squamous cell changes. Okay. Squamous cell changes can be defined as an atypical squamous cell. Okay. And this can be further classified into atypical squamous cell of undetermined significance, and one that is where you cannot exclude HSIL, that is high grade squamous intraepithelial lesion, which you will be writing it as ASCH. Okay, so this means undetermined significance, and this means you cannot rule out HSIL. Okay, that means ASCH. And the next type is, it can be a low grade squamous intraepithelial lesion. Okay, already we have seen low grade squamous intraepithelial lesion means it comes under CIN 1. that means mild dysplasia, right? And this is mostly due to HPV infection. So, that also will be mentioned. Clear? And the next one is high grade squamous intraepithelial lesion. So, that will include your CIN2 and CIN3 as well as your moderate and severe dysplasia. Okay. So, here you have to mention whether there is any features of invasion or present or not. Okay. And the final diagnosis they can give you is squamous carcinoma. It can be a squamous carcinoma. Okay, so these are the possible diagnosis of examining a squamous cell. It can be atypical squamous cell which can be of undetermined significance, or a cannot be ruled out where HSIL is present or not, or it can be LSIL, or it can be HSIL, or it can be a squamous carcinoma. Clear? Right. Now coming to the glandular cell abnormality. Okay. So, glandular cell abnormality. First one is atypical glandular cell. That means you can have cervical cells of NOS, or you have to, that will be specified especially in the comments. No observed significance, NOSs. Okay. Then endometrial cells of NOS, or if anything they will specify you in the comments. And then glandular cells NOS, that will be specified in the comments. Okay. And another level is, suppose if the endocervical cells are favorably neoplastic, maybe neoplastic, the same way the glandular cells are neoplastic or not, that will be mentioned. And suppose if there is a carcinoma, that will be mentioned as endocervical adenocarcinoma. Okay. So, this adenocarcinoma can occur from anywhere, right? It can occur endocervical, we have already seen. It can be even endometrial adenocarcinoma, or even an extrauterine adenocarcinoma, or not otherwise specified. Okay. Suppose if they be able to make out any other malignant neoplasms, means that will be mentioned separately. Okay. And if you see abnormal cells in the pap smear or in the report they have given, then it will be proceeded with colposcopy, cervical biopsy, and then yes, fractional curettage. Anything will be done. Okay. If any abnormality is seen, it will be proceeded with colposcopy, cervical biopsy, or a fractional biopsy. Okay. Right. So, this is all about Bethesda system. So, we have seen what is pap smear, how it will be taken, and what is the reporting system will convey you. So, it is a detailed report, that is Bethesda report for cervical cytology, that came out recently. Clear? Yes. Now, another important investigation you have to know is HPV DNA testing. Okay. So, here what you will do, you can even combine this HPV DNA testing with your pap smear, and that time this can be mentioned together as co-testing also. Okay. Suppose you do a pap smear first, then if any abnormality is present, then you offer her HPV DNA test, then this is called as reflex testing. Okay. So, mostly HPV DNA is offered more than or equal to 30-year-old women, and if it is less than 30 years for the patient, means then you have to know there is high prevalence for HPV infection which is transient, and it should be used as a primary screening also. Clear? Right. That means HPV DNA can be used as a primary screening. Clear? Right. Now, let's discuss about VIA. What I told you, what is VIA? It is visual inspection, yes, after acetic acid. Acetic acid, when applied to cervix, coagulates with the mucus as well as area of the cells which have increased chromatin density. Okay. So, at this point when it is applied, that particular area will appear white. Okay. So, what may be these areas? These can be areas of cervical intraepithelial neoplasia or even a site of neoplasia itself, or changes of HPV virus related effects are seen, and any other abnormalities. Okay. So, all these things will appear aceto-white. Okay. So, this method is used as a primary screening method in many developing countries. Okay. And also you have to remember, specificity of visual inspection of acetic acid is limited to 80%, and also there can be false positive rate which can be high also. So, that means most of the patients after getting a acetovate area will need referral for further evaluation. Clear? So, this is before application of acetic acid, you are able to see that is the whole thing is homologous. Okay, you are not able to differentiate anything, but after application of acetic acid, you are able to make out these aceto-white areas which are distinctive from that of the normal cervical layer. Clear? Right. Now, coming to the next one, which is VM, that is visual inspection after magnification, acetic acid and magnification. This is nothing but you are going to magnify it. Okay, usually this will be a handheld magnification lens. Okay. Yes. Next is villi. Villi means, yes, visual inspection with Lugol's iodine. So, after application of iodine, normal cervical epithelium, this one has rich content of glycogen, so it stains mahogany brown in color. Okay, so this test is also known as what? Schiller's test. Okay, remember here the normal regions are those which have brown painted color. Okay. Yes. So, the abnormal areas say the columnar epithelium, okay, or what? Columnar epithelium, or areas that are lined by immature metastatic epithelium. Okay, do not contain much glycogen and they will appear mustard yellow in color. Okay, so this has the same specificity and advantages and disadvantages like that of your visual inspection after acetic acid. Okay, so this is how the lesions will be. Yes. So, this is a native cervix and this is just after application of your Lugol's iodine. Okay. So, this lesion, if you see, it is uniformly stained everywhere except that you have a mustard yellow color here. Okay. Near the transformation zone, but here you have a mustard yellow color, right. So, that has to be considered. There can be any lesion over there. Okay. Right. Next one is colposcopy. Colposcopy is nothing but a procedure that is done to visualize the cervix directly, okay, and even you can visualize the vagina, and it will be done under magnification, vagina as well as vulva also, okay, under magnification, so that we will be able to detect pre-malignant or malignant lesions, okay. For this, the procedure, the patient, so this is colposcopy, okay. So for this, the patient should be in lithotomy position, okay. So it will be magnified and seen. Clear? Yes, the patient should be in dorso-lithotomy position, and you have to insert speculum, then use a focusing colposcope on cervix. The lesions will be noted with low power initially and then move to higher power for better visualization of the lesion, okay. And also note that lesions are noted after application of 3% acetic acid as well as after application of Lugol's iodine. The advantage of colposcopy is that you can take a simultaneous biopsy if needed. Clear? Right. Now, let us discuss about the abnormal colposcopy findings. Abnormal colposcopic findings. First one is grade 1, where it can be fine mosaic pattern or it can be a fine punctuation also, okay. And grade 2, where there can be a coarse mosaic pattern or coarse punctuation with sharp border having a ridge sign, and if there is any suspiciousness for invasion, that is where atypical vessels will be seen, okay, right. So this is how the abnormal colposcopic findings will be seen. Grade 1, there will be a fine mosaic pattern or a fine punctuation. Grade 2, where it will be a coarse mosaic pattern or a coarse punctuation with a short border ridge sign, and there will be invasion that will be seen with atypical vessels. Clear? Right. And the next one is endocervical curettage. Endocervical curettage. So this is done to rule out any lesions in endocervix especially, okay. So this will be done when transformation zone is not entirely visible, or you suspect some lesion in transformation zone but it is not visible, okay. Cori lesion if it is present in transformation zone, okay. And you have to know this thing is not definitely performed during pregnancy, okay. Now let us discuss some of the screening guidelines. Screening guidelines, okay. So you should begin screening at the age of 21, okay. And from age 21 to 29, you should screen every 3 years with pap smear, and there is no need to use HPV DNA testing. Clear? And suppose if you are between 30 to 65 years, then screening should be done every 5 years, okay, every 5 years with co-testing. What is co-testing? We will use pap smear plus HPV DNA. Okay, and then you can screen them every 3 years with pap smear alone, because HPV DNA is somewhat costly investigation. So, you can offer it once in 5 years, or if she is not affordable for HPV DNA at all, then you can provide it once in 3 years with your pap smear alone. Okay. So, this is how you will continue screening, and you have to stop screening if she attains the age of 65 or all the previous smears taken so far are negative. Okay. And no screening is done after hysterectomy. After hysterectomy, there is no need for screening. Only for CIN2 and CIN3, you have to do. That means for CIN1, you are not going to do a screening. For CIN2 and 3, you are going to continue screening. Clear? Even if hysterectomy is done. And then you have to continue screening even if these people are treated also. Okay. Then for taking pap smear, either conventional or LBC can be used, and women at high risk for cervical cancer, if they have any other high risk for cervical cancer, then they can be screened even more frequently also. Okay, so that is not mentioned in the guidelines like how frequently we can screen, but it is mentioned that if they have any additional risk factors, we can screen them even more frequently. Clear? Now, there is a WHO approach which will be speaking about the screening as well as the treatment management of these people. Okay, so there are two approaches. One is screen and treat approach. Okay, screen and treat approach means VIA is used as a primary screening test, and this will be followed by treatment. This is one option. Okay. The second option is you can use HPV DNA detection as a primary screening test, and this will be followed by treatment. So, the word itself says, repeating, the word itself says you are going to screen and treat the patient at the same setting, that is screen and treat approach. Clear? Right. Now, next approach is screen, triage and treat approach. Okay. So, in this we can use cytology as a primary screening test, okay, followed by colposcopy for triage, then this will be followed by treatment. Okay, so this is one option. Next option is we can use HPV DNA detection as the primary screening test. Okay, so I am confusing, right? So I will write it like this. So this will be used as a primary screening test. This will be used as a primary screening test, and this will be followed by, when HPV DNA is positive, you have to check for HPV 16 or 18 triage. Okay, when already present positive for HPV test, then you have to check whether it is 16 or 18. Okay, so this will be the triage, and after this it will be followed by treatment. Okay, or you can even triage these people if they become positive for HPV 16 or 18. You can again triage them using VIA, that is VIA positive or VIA negative, and then take them to the treatment. Clear? And the next option is they are HPV DNA positive. Okay, that will be used as a primary screening test. That will be followed by VIA triage, and that will be followed by treatment. Okay, and the next option is HPV DNA as a primary screening test followed by, yes, we can also use colposcopy for triage. Okay, then that will be followed by treatment. And finally, yes, HPV DNA as a primary screening test, that will be followed by cytology triage, and that will be followed by colposcopy and treatment. Through colposcopy only we can treat also. Okay. So, these are the various options where screen, triage and treat can be done. Okay. First, you can offer them a simple cytology that will be followed by colposcopy triage and you can treat them. Second option, HPV DNA detection can be done as a primary investigation, that is a primary screening investigation, and triage can be done by choosing which HPV infection is present, whether 16 or 18 is present, then according to that you can treat. Or if they become positive for HPV DNA, again you can give a via triage, then after that you can check whether they are via positive or via negative, and if they become via positive only you are going to treat them like that. Okay. And for third option, you have primary screening test for 3, 4, 5 primary screening test of HPV DNA, and the triage options will include via cytology as well as a colposcopy. And if you are choosing cytology as a triage option, then you have to go for colposcopy. Okay. So, colposcopy will be serving as a confirmation investigation also, but through colposcopy you can treat the lesion if anything is present. Clear? So, yeah, these are the two approaches that are used by WHO. Clear? Now, so this again has some significance, okay, a significant consideration. You have to see the general population, okay, repeating. You have to consider the age according to whether they belong to a general population category or not. If they belong to general population means, then you can begin at 30 years and you can do regular screening for every 5 or 10 years. Okay. And suppose if the woman is having HIV, then you will offer her screen, triage and treat approach. You will begin at 25 years itself, 5 years earlier itself, and regular screening should be offered every 3 to 5 years. Clear? Now, let's discuss about some of the treatment modalities of cervical intraepithelial neoplasia. First thing I am going to discuss is, yes, cryoablation. Okay. So, what are the criteria for cryoablation? So, criteria for cryoablation will be, you don't suspect any invasive cancer, then transformation zone is completely visible and the lesion does not extend into endocervix, and finally the lesion is in type 1 transformation zone. Okay. So, who should not be treated by cryoablation? That is also important. Who should not be treated by cryoablation? This includes CIN3 or a HIV positive woman. Okay. And know that cryoablation is an OPD procedure, and let me tell you the principle behind this procedure. Okay. Principle behind this procedure also. So, we use carbon dioxide or nitrous oxide at a very low temperature, and this will lead to crystallization of intracellular water, or it can result in cryonecrosis. Okay. So, how will you do this? You will have some cycles repeated, that is freeze-thaw cycle. Okay. So, like this it will be repeated again and again. So, freeze for 3 minutes, then thaw for 5 minutes. The same way, freeze for 3 minutes, thaw for 5 minutes. Okay. So, likewise this will be repeated. Okay. Let me tell you what are the limitations also Limitations means depth of invasion only up to 5 millimeter. Okay, depth of invasion up to 5 millimeter only can be treated. Okay, and then you will also have some side effects with this procedure, like there can be any watery discharge or bleeding. Okay, let's discuss about the disadvantages of this procedure. We can't take a biopsy of the lesion. Okay, then how will you follow up this patient? You have to take pap smear and colposcopy for 4 to 6 months, and if they are positive in any stage, you can treat them with LEEP or LETS. Okay? Yes. Now, let's see how cryoablation is done. Okay, so cryoablation, this is actually ablation of endometrial cavity. This pic only I got, but it is somewhat similar to a cryoablation of the CIN lesions also. Okay, you will be having a cryoablator that will be introduced, and from that you will be doing the freeze-thaw cycle for 3 minutes, 5 minutes, 3 minutes, 5 minutes respectively till the lesion is removed. Clear? Follow-up is very important, and you also should know when you should not do cryoablation, that is CN3 as well as HIV patient you should not do, and this is an OP procedure. Okay, right. Now, next one is LEEP or LETS. Okay, large loop excision of transformation zone. Yeah. So, let me tell you what are these abbreviations first. LEEP is large loop excisional procedure. Okay, LETS is large loop excision of transformation zone. Okay, and remember, both of these procedures are OPD procedures, and the time taken will be only about 10 to 15 minutes. If needed, you can prefer to give local anesthesia also, and we will use a wire loop, cautery, and a straight wire can also be used, that will be known as SWITS. Okay, so it is SWITS. It is SWETZ. That means straight wire excision of transformation zone. Okay, then the advantage of this is it cut and coagulates at the same time, and you can obtain tissue for biopsy. That is also possible. Okay, so obviously now this becomes the treatment of choice for CIN2 as well as CIN3 if they are of any age group or any variety. Clear? Yes. Now let's see the procedure. So this is large loop excision of transformation zone. Okay, we have a loop like appearance of the instrument, that's why it is called as a loop excision. Okay, right. Next option is conization. So conization, the sample is taken in cone shape with the base of the cone at ectocervix and the apex of the cone will be in endocervix. Okay, and this also requires anesthesia. Okay, and remember, conization is a OT procedure. You need OT to do this procedure, and excision of the sample will be in the shape of a cone that will be done using a scalpel or a cold knife. Okay, and to secure hemostasis, there can be a need for suturing or even cauterization as well. Okay, and after this you have to do vaginal packing also. Clear? Right. Now let me show the picture of conization. So yeah, this is a picture to show how conization will be done. Okay, so here they will be taking a cone like shape of the cervix, where the base will be at the ectocervix and the apex will be at the endocervix. Okay, so just like this, a cone like sample will be taken and this will be taken for biopsy. Okay, right. Now let's discuss what are the complications of conization. Yes, there can be hemorrhage, infection, because this is somewhat invasive procedure, right? Yes, there can be cervical stenosis or cervical incompetence or even preterm labor. Clear? Yes. Now let us discuss how management of CN can be done in short. So management depends upon the type of CN. It can be type 1 CN1 or it can be CN2 and 3. Okay, remember when it is CN1, there is no need to treat. You have to understand that point first. Okay, no need to treat, and this mostly regress within 2 years, and suppose even after 2 years it is present means you have to check for that. So you have to repeat for the test, and if it is still positive, then you can go for cryoablation or LEAP, okay, which are OPD procedures and very minimally invasive procedures. Clear? And in case of CN2 or 3, you will directly offer them cryoablation, or you can offer them excisional procedures like LEAP or LETS or yes, even your conization. Clear? So this is all about cervical intraepithelial neoplasia. I hope you would have got an idea on the topic. But still there are some more components to be discussed under the same topic. I'll be doing it in another video. So let's all meet in the next video. Until then, keep going, happy learning, take care and bye bye.